morning, dignitaries sitting on the dais of the dais and delegates. So I will be talking about advanced glaucoma management. So when we say advanced glaucoma, what is that? As per the International Classification of Disease, any evidence of glaucomatous optic disc and visual field, both in the upper and lower hemifields, or encroaching 5 degrees of the fixation is advanced glaucoma. So any CD ratio of more than 0.8, mean deviation on visual fields of more than 12, advanced visual field defects, macular split, all if only temporal vision is left, they all are suggestive of advanced glaucoma. So we avoid the term end-stage disease just because it gives a pessimistic effect on the patient also. So let's see how big is the problem. When we see early manifest glaucoma trial, out of 32,900 subjects they screened, they found that 1.23% patients were previously undetected glaucoma, and out of those undetected cases, 33% patient had advanced visual field loss. Similarly, other trials also found that the advanced glaucoma has got pretty high number and it gets undiagnosed due to certain reasons. The goals of the therapy in advanced glaucoma, of course, is achieving target intraocular pressure. But besides that, it is also important to ensure that there is controlled diurnal variation in patients and there is no fluctuation in intraocular pressure. Therefore, there is no progression on visual field along with good quality of life of the patient. That is also very, very important. And therefore, we need to give holistic approach to our patient. That is, we need to consider the bio-psychosocial-spiritual profile of each patient besides aggressive IOP lowering. Like, we need to consider the systemic biology of the patient. What is the mechanism of glaucoma? What is the level of IOP? How is the rate of progression? And what is the life expectancy? There, we also need to consider the general health of the patient. If patient is having asthma or cardiovascular disease, we need to defer starting them on beta blockers. Similarly, other issues. Similarly, if psychological considerations, they also need to be considered, like if patient is on depression and the medication is increasing this factor, then we need not to start those medication. Socioeconomic factors we all understand is very, very important consideration because we need to give cost-effective therapy to our patients. It is a lifelong therapy. And then spiritual and cultural values. Suppose the patient who is fasting throughout the day, they will not use the medication if you give them 3 times daily. So tighter as per their own requirement. So first and foremost thing is establishing a target intraocular pressure. Now if we see the European guidelines, in advanced glaucoma it should be less than 12 millimeter of mercury. If you can keep it in single digit, it is well and more important. But besides this, it is also important to make sure that we consider other factors also. Like if life expectancy is longer, we need to have lower target intraocular pressure. If untreated IOP is low, we again need to have lower target intraocular pressure. We need to consider other additional risk factors for our patients and then, as I said, rate of progression. Fast progressors should have lower target intraocular pressure. Now, when we say decision regarding the medical therapy in advanced glaucoma, medical management is definitely the primary intervention which we all do, but we need to give maximal medical therapy so that we get the target intraocular pressure, which is 4 drugs and 2 bottles nowadays. But besides this, we need not to miss certain important things like visual field. If patient is not able to perform on Humphrey's visual field, we have to go for Coleman visual field. Similarly, compliance and adherence is very, very important part. If patient is compliant, then only we can avoid the fluctuations in intraocular pressure. Check the bottles yourself. Instruct the whosoever person is instilling the eye drops. He may be needing, he may be using some of his relatives, friends to instill the eye drops. Just tell them how to do it properly so that the patient gets the adequate amount of medication. We can resort to preservative-free eye drops so that patient does have lesser side effect and therefore improves the compliance and adherence. And punctal occlusion is another very important thing which we need to instruct to the patient and to the relative also. The first and the most important thing which I felt is that we need to keep the hope alive in the patient's mind so that he has a good quality of life and feels optimistic while dealing in these cases of advanced glaucoma. Now coming to surgical therapy, we need to aim the risk and benefits of the surgery against the risk of progressive vision loss. So when to shift these patients? Whenever there is unacceptable risk of glaucomatous progression, we need to shift. If we are unable to achieve the target intraocular pressure, or there is poor diurnal control of intraocular pressure, or there is poor compliance and adherence, then we need to shift. Now, this was a Cochrane review which found 4 relevant studies comparing medical and surgical therapy, and they found that the medication was associated with more progressive visual field loss and less IOP lowering than surgery. Therefore, we can have a lower threshold for these patients regarding surgery. Now, when we say which surgery to choose, there are so many surgeries coming up, microincision glaucoma surgeries are coming up, but in all cases of open-angle glaucomas, NTGs and non-inflammatory glaucoma, trabeculectomy is still the gold standard surgery and tried and tested surgery with long-term results. In neovascular glaucomas, inflammatory glaucomas, or glaucomas where already trabs have failed, you can comfortably do tube shunt surgeries because now they have got good results, but then an expert is needed to do these surgeries, especially in advanced glaucoma. So if you are an expert, you can do it yourself, else better to refer these for tube shunt surgeries. For painful blind eyes, of course, cyclodestructive procedure are the choice. Now, the patients of PACG with cataract, especially in advanced glaucoma, never do only cataract surgery. Always go for combined surgery because there is a misconception regarding it. And I would like to emphasize that in advanced glaucoma, combined surgery in PACG with cataract patients. Now, whenever you are going for a trabeculectomy surgery, which is the gold standard surgery, certain things are very, very important in your patients whenever you are planning, like preoperative mannitol you have to give. If you can do under topical or subtenon anesthesia, it is good. If you are giving a peribulbar block, give small amount of anesthesia and small dosage. Don't inject bigger amount, large amount of anesthesia altogether in peribulbar area. Another thing is never apply pinky ball in already compromised optic nerve head. You can give intermittent digital massage so that there is not sudden onset increase in pressures which might lead to a wipeout phenomena in your patient. Another important thing is you have to avoid sudden lowering of intraocular pressure. So make a side port and avoid any hypotony during the procedure so that you don't land up into shallow anterior chamber. You can always use cause modification, which is the Moorfield safe surgery system, to give results to your patients. So, do I have the time?
I think your time is over, but if you want to make a specific point, it's okay because we don't have other speakers. So yeah, we can give you another 2 minutes.
Okay. So the main concern is that unexplained irreversible loss of central vision we need to avoid. And because after trabeculectomy surgery, vision definitely drops down by few lines. So explain the patient beforehand that initially there will be drop in the vision and later on you can regain your vision. Another important modality which I found is useful in these patients whenever you cannot resort to surgery. Suppose there is a patient who is old and frail and you cannot take him for immediate surgery like if he is needing, then you can go for some laser procedure to bypass that small phase and later on go for surgery. So adding laser therapy, it can be a micropulse laser or a laser trabeculoplasty along with anti-glaucoma medication to bypass that small phase of problem. So surgery is contraindicated. If patient is not giving consent for the same, you can go for this laser, which definitely controls the intraocular pressure for short term, although later on pressure tends to rise in many of the patients. So micropulse technology is another thing where you get small pulses of laser with intermittent areas where you don't get any lasers. Therefore, the reduction in vision which is seen with other cyclodestructive procedure is not seen in this kind of laser. So in micropulse laser, you can take up the patient under topical anesthesia, and then you can simply apply the probe at the limbus, and it is kept 2 millimeter away from the limbus, and then you can sweep it 180 degrees superior and inferior, leaving the nasal and the temporal areas, and therefore the patient gets reduced intraocular pressure without much increase in inflammation. Now in cyclocryotherapy, there is lots of inflammation which is there seen in immediate post-operative period, which is not seen with this kind of micropulse laser. So we have our experience with certain number of patients and in variety of glaucomas, but in primary open angle glaucoma, we found a sustained decrease in intraocular pressure, but other secondary glaucomas, it was a mean reduction was good, but later on the pressures, they started rising up. So the take-home message is that we need to do aggressive IOP lowering in all patients of advanced glaucoma. It is not just IOP lowering, it is the holistic approach we need to give to our patient. We need to have lower threshold for surgical management, and we can combine sometimes laser with anti-glaucoma medication if surgery cannot be resorted to. Thank you so much for your kind attention.